Good afternoon, everyone, and welcome to CEDA's livestream on maintaining momentum in mental health reform and services. This is the second event in CEDA's 2022 mental health series that brings to the fore the importance of integrating state and Commonwealth investments, strategies, and services in mental health. My name's Cassandra Winzar, and I'm a senior economist at CEDA, the Committee for Economic Development of Australia. CEDA acknowledges that today and every day we're on Aboriginal land. Committed to recognition and reconciliation, we respect elders and we support their stated aspirations. Today, I'm coming to you from Perth, on the land of the Wodjuk people of the Noongar Nation, and I'd like to pay my respect to their elders past, present and emerging. We encourage you to join the conversation today by following CEDA on Twitter at CEDA_Nous and tag any comments on today's discussion with the hashtag mental health. And you can participate directly in today's discussion by asking questions using the Pigeonhole app. You can enter via the livestream page or log in via ceda.pigeonhole.at with the password momentum. On Pigeonhole, you can either enter your own questions or also view and vote on the questions of others, so I know which ones are most important to the audience. And at the end of today's event, we also ask that you rate your experience in Pigeonhole. I'd like to thank our livestream sponsor today, St John of God Healthcare, for their support of this event. Without the support of our sponsors and members, CEDA is not able to convene these important discussions. Mental health is an important social and economic issue. The Productivity Commission's inquiry into mental health in 2020 estimated that mental illness is costing the Australian economy around $70 billion per year, with a further $150 billion per year of associated costs of disability and premature death due to mental illness. Much of this is preventable, but mental health services are often fragmented, difficult to access, and expensive. The National Mental Health and Suicide Prevention Agreement was signed earlier this year, with aims to improve the mental health of all Australians, reduce the rate of suicide towards zero, and ensure the sustainability and enhance the services of the mental health system. These are certainly lofty goals, and I look forward to hearing from our panellists today on the outlook for meeting them. CEDA is currently undertaking research around the role of employers in mental health, which we expect to release before the end of the year. So please watch out for more from us on this topic. We have three fantastic panellists today, and I'm really looking forward to what they have to say. We have Professor Samuel Harvey, Executive Director and Chief Scientist at the Black Dog Institute. We have Tim Marney, who's Principal and Chief Economist at Nous Group, as well as Chairperson of Richmond Wellbeing. And Colman O'Driscoll, Chief Executive Officer, Burwood and Richmond Hospitals, and Group Lead Mental Health Strategy at St John of God Healthcare. Each of our panellists will give some brief introductory comments, and we'll then have a facilitated discussion. So please start putting your questions in Pigeonhole now. I'd now like to invite Samuel to make his opening comments, and he'll then be followed by Tim and Colman. Thanks, Sam.
Thanks, Cassandra, and thanks to CEDA for inviting me along to be part of this discussion. Just for those of you that haven't heard of the Black Dog Institute, we're a medical research institute. We're based in Sydney, and our focus is on understanding mood disorders and suicide prevention. And like all research institutes, what we try and do is good science to answer some of those key questions about how can we improve the mental health of Australians. What we feel differentiates us from a lot of mental health institutes is that we also put an equal focus on the implementation of those results. So we do both the science and the action. And in this setting, one of the ways in which we try and do that is through being an active part of policy discussions and trying to be that voice of mental health science. When I think about mental health reform in Australia, I'm not sure momentum is quite the phrase that comes to mind. I have a slightly cynical view where I feel really the Australian public has been somewhat tricked into thinking there has been more mental health reform than there actually has over the last decade or so. And I say this for two reasons. Firstly, we've had wave after wave of mental health awareness in this country. We really lead the world in mental health awareness. And in some ways, that's been a good thing. But there's increasing evidence that mental health awareness by itself doesn't do much good. Indeed, it might create harm for some people. Further, I really struggle to think that Australia now has a mental health awareness problem. If you go to any GP waiting room anywhere around the country, it's absolutely full of people trying to get help for mental health problems. The real barrier is that they can't get in to see a psychiatrist or a psychologist if that's what them and their GP want, without a 6 to 12 month waiting list almost everywhere. I think the second part of where I feel the previous attempts at mental health reform have gone astray, and that we've been sort of somewhat tricked into thinking that more is happening than really is where we have had new innovations of new service models. They have been rolled out in a way that's not at all integrated, well, is very limited integration with the existing health services, where there's often inadequate staff to fund them appropriately. And when evaluation has occurred, that evaluation has often been pretty borderline as to whether some of these new interventions are helping. And so what we have is we have a lot of fanfare about mental health awareness. We have a lot of ribbon cutting ceremonies of opening up new mental health services, but actually in terms of outcomes for patients or people coming forward to get help, we're not really seeing much of a benefit there from any of those things. So for me, I think what we need to be focusing on are the real issues, which is firstly, the mental health workforce. We need an adequate number of mental health workforce in Australia, which we just don't have at the moment, and we need a realistic plan on how to get there. Secondly, we need to have adequate funding into the mental health services. We need the funding to shift to match the changing burden of disease. And then thirdly, we have to look at models of care and how we use those resources and make sure the funding matches those. So that's what I think we need to be doing to maintain the momentum. As I hear myself, I realise I'm sounding sort of rather negative about it, and I apologise for that. But I think there's lots of reasons to be really positive. I mean, we've had some building blocks, even though I'm very down on mental health awareness, it was an important first step. We're now at the point of having these types of discussions. We've actually got really impressive evidence around what works in terms of treatment and to a lesser extent prevention. So, we can get on and make a real difference. We just need the motivation, the money and the people to do it. So with that, I will hand over to Tim for his opening comments.
Excellent. Thank you, Sam. A few little controversial nudges there, which is great and should make for a lively discussion. I do tend to agree with you. Awareness by itself is not enough. It's got to be coupled with action, and it's got to be coupled with action in implementation of expansion of services, improved access to services, and new models of care to address particular areas that are quite complex and challenging, and also quite prevalent. For example, conditions such as borderline personality disorder, which requires a very different approach to mood disorders, for example. In terms of momentum, I agree with Sam. We don't actually have enough momentum at the moment, and we need to build greater momentum. We've certainly had enough reviews, Productivity Commission inquiry, Royal Commission in Victoria, recent Parliamentary Committee inquiry in Queensland. There are plenty of recommendations out there, and they're all very similar. But merely accepting the recommendations is not implementation. The implementation challenge is substantial and needs considerable focus, energy, effort, and resourcing. Part of the implementation challenge is robust planning. And from the National Mental Health Services Planning Framework, we know that community support and earlier intervention, treatment and care is woefully inadequate relative to the prevalence of mental illness in the community. And we also know from the Productivity Commission that there is a lack of services for what they referred to as the missing middle. As part of evaluation work that we've been doing at Nous, we've actually found the missing middle. And it's those people who have mild or moderate mental health issues, but at times with severe symptoms and functional impairment. Their, if you like, their conditions are too severe for just a GP mental health plan and a psychologist intervention, but not sufficiently acute that they actually meet the threshold for entry into state-funded systems. So as a result, they're left in the middle with no services and supports. So we know we have to address that. In addressing mental health issues in the Australian community, we need to focus on evidence, and we need to continue our effort, and if not increase our effort, in evaluation of new ways of doing things, and indeed evaluation of long-standing models of care, which may or may not be optimal for people with mental health issues. Gaining momentum is also about advocacy, and advocacy is absolutely essential, and we need to support consumers and carers in particular at a system level and at service level to inform the design of the mental health system and services and models of care, because it's those people with the living experience that know best what works for them and what doesn't. And we also need to go broader than models of care. We know that mental health outcomes are significantly impacted by social determinants. So social determinants such as safe and stable housing, access to education, access to employment. These factors are all critical ingredients to people's good mental health and to recovery from mental illness. And of course, we have to implement what is feasible. And our workforce situation at the moment is such that we need to think very carefully and deliberately about where we deploy that scarce workforce. And that comes back to system-wide planning and system design, not just adding new services and plonking them into the system. So those are my thoughts. I will hand now to Colman, who will pick up from there.
Thanks, Tim, and thanks, Cassandra. It's great to have these events on and to have the discussion happening. So yeah, really pleased to be here. I wanted to just quickly pick up on a point that both Tim and Sam have made about workforce, and it reminds me of the analogy with daylight savings. You know, the more services you fund out there, and the more avenues for access into services and into care that you create, without adding to the pool of people available to deliver that care, seems to me to be the kind of trickery that Sam is talking about. It's a little like daylight savings. You know, if you take an hour off the end of the day and put it on the other end of the day, you don't have a longer day. And so if we create more avenues for people to access care, but we don't increase the pool of people and specialists available to deliver care, then we shouldn't be surprised when things don't improve, because we have a very big workforce challenge in health and in mental health that's fundamental to addressing this problem. What I also wanted to sort of touch on was, and apologies, Tim, I know you're an economist, but often we make the case that that addressing the mental health care needs of our community is an economic problem, that we talk about the economic impact of mental ill health on the Australian economy and so on. I think sometimes we're a little misguided in leading with that. I understand why we do it, and I think it's important. But fundamentally, this is a human problem. People with serious mental illness die earlier than your average Australian, and I think that's what we should be focused on here. This is about helping members of our community to live full and meaningful lives, and not have them prematurely end because they happen to have a mental health problem or a mental illness. So keeping the why at the center of all of this is important. Sam also touched on issues to do with whether or not we actually have momentum. And I think that's fundamental to the question. I think both Tim and Sam have touched on that. It's not about how do we maintain momentum, but really how do we generate momentum? Because I'm not sure that momentum is really there, despite the funding increases we've had over the years. I don't think those things have translated into meaningful change across our mental health system. And so when I think about how do we generate that momentum, or where do we go, for me, the systems that we operate within are fragmented. We've talked about that already, and that fragmentation is in part, I think, largely driven by the way in which we fund care. Our care models come second to our funding models, and we often expect them to adapt to our funding models. And our funding models are very transactional. So it seems sensible to me that if you fund transactionals, you then end up getting transactional care. And in a mental health context, I think that is very unhelpful. It really isn't supporting people in the way that it needs to. So our challenge for me here is, how do we reshape our system so that it puts the person at the center of how we design our models of care, and that we adapt a funding model to deliver outcomes rather than continually measuring inputs. I mean, we've had lots of fanfare. We've talked a lot about how much extra money has been spent in the mental health care system over the last decade and a half, but we rarely talk about outcomes. We rarely talk about what has been achieved, because I think it's very hard for us to quantify what's been achieved. And so that's got to be central. We've got to stop sometimes doing things that don't make sense, and we've got to start doing things that actually have some evidence behind them, and evaluate the investment and be able to demonstrate that we're achieving things with our investment. For me, that's our biggest challenge. And I think if we want to create momentum, and I don't, like Sam, I don't want to sound negative, because there's a lot of good things there. But if we want to create more momentum, I think we've got to be more unreasonable. We've got to stop accepting things as they are and try to create things as they should be. And that means tackling, in my view, some very difficult areas in public policy. So for me, that's the challenge ahead in terms of generating momentum.
Great. Thanks, Colman, and thanks to all our speakers for their opening comments. Certainly a bit of kind of stark reality there, but I think there's a lot of goodwill amongst the people on this call and people listening in as well about wanting to change things. So hopefully we can be part of that conversation. We've got some questions starting to come through on Pigeonhole, which is absolutely fantastic, but please keep putting those in and voting on which ones you're particularly interested as well. It makes my life much, much easier. So please stay on Pigeonhole. I might start with talking a little bit about the funding challenges in a bit more detail. And Tim, I'll start with you. You've had quite a lot of experience over here in WA as the Mental Health Commissioner. So you've dealt with the kind of big budgets and having to kind of understand that and prioritise services. Do you want to give us a little bit of your experience kind of dealing with those budgetary challenges and the role of funding and issues there?
Yeah, I agree with a lot of what Colman has said. I think from a funding perspective, people often focus just on funding as the key enabler, when in actual fact, the starting point in funding is actually strategic commissioning, which is about needs assessment, identifying the best way to meet those needs and identifying the best way to deliver services to meet those needs. I think then funding kicks in as the enabler, but often is far too restrictive and is input driven. Or at best output driven, as opposed to focusing on outcomes for individuals and allowing flexibility in the way in which services respond to the often complex and multiple needs of individuals in their recovery from mental ill health. So flexibility is a key in an outcome-focused funding paradigm. I think then the final part of that whole funding question is around evaluation, and really being quite diligent and rigorous about questioning whether or not the outcomes intended are actually being achieved, and whether or not there's better ways or better outcomes could be achieved through different mechanisms, different models of care, and indeed different funding mechanisms. So unfortunately, our budgetary processes are almost perfectly designed to work against strategic commissioning, outcomes-focused funding and evaluation. So there does need to be, I think, a shift in the way that we think about funding in the context particularly of mental health, but across a whole range of human service areas, including broader health. The same issues apply in the broader health system, and the need to focus on value-based healthcare.
Thanks, Tim. And I think you're absolutely correct that these are issues for mental health service provision, but it's throughout the kind of spectrum of really all services. We see this lack of evaluation, and a lot of what mentioned today, this focus on kind of transactions and outputs and inputs, and rather than really looking at the outcomes and what we're trying to achieve. Sam, I might throw to you. You mentioned in your opening comments that we have really good evidence of what works around prevention and intervention. Given we have that, what is kind of the blocker there to kind of the implementation? What do we kind of need to do to take that evidence and actually put it into practice?
Okay, I think we have very good evidence about what works for treatment. And I think we have building evidence around what works for prevention. So I think in terms of treatment, we know what works for, and of course it does differ between different disorders, but, if we think about the common mental health problems like depression and anxiety, we've got a combination of medications that we know are effective, particularly if you combine it with different types of talking therapy. We know that if you want to get people to be able to get back into work, you have to have a level of vocational rehabilitation to it. So the question as to why that's not happening, I think there's a couple of reasons. I mean, one is it goes back to the issue of the staff numbers and the size of the workforce we have. If you go to most community mental health teams that are operating, they're struggling to just do the basics of the number of patients that are coming into their service, just trying to keep people safe and dealing with crises. There's just not the capacity to do all the extra things that we know could actually help keep people well for longer. Similarly, even GPs wanting to refer someone to a private psychiatrist and psychologist, there's often a 6-month wait. So that might be 6 months without that person getting sort of the full package of evidence-based treatment that they should be getting. I think the third thing is, the current funding models we have for health in general, but perhaps particularly for mental health, are sort of slightly blind to the outcomes. And so, as a psychiatrist, I get paid a certain amount for spending an hour with a new patient or half an hour and a follow-up patient. No one, it doesn't really matter what I do in that session. That doesn't have any impact on the model. And of course, the problem is it's very, very hard to come up with a model that actually would do that. That doesn't get in the way of patients and their team being able to make flexible decisions. But I think there's a lot of factors working against people getting the appropriate care for treatment. Just very quickly to touch on what was actually your question, which was around what might work for prevention. I think there's reasonable evidence for 3 things probably broadly for prevention. I mean, we know probably the most effective thing you could do to prevent mental health problems in society is to try and reduce the amount of kids who are having traumatic early life experiences, and we could try and reduce social inequality. Now, that's well outside the remit of a psychiatrist to do that, but they're the things that would make a difference on scale. Beyond that, there is stuff that we increasingly know we should be doing in schools around what sort of skills we should be teaching kids. But at the moment, sort of principals, it's largely left up to them to work out what it is they do. And there's a whole lot of companies out there making money flogging stuff that doesn't really work. But, how do we expect schools to be able to pick what does work and what doesn't work? Similarly, in workplaces, we know what works. We've got really good evidence for the type of training that managers in workplaces should get. And we've shown that reduces rates of mental health problems within their teams. But, again, if a workplace decides it wants to do something around mental health, it'll, often get bombarded with different organisations that want to sell them EAP and resilience training and other things. And so it's really hard for them to be able to pick what it is they should be doing.
Fantastic. Thanks, Sam. Some great ideas there of things that we could be doing more of. So that is great. Look, it's probably not surprising. It's kind of run through all the themes of the comments so far. And it's the number one question on Pigeonhole is around this workforce issue. And look, clearly it's not just an issue in mental health services at the moment. Apparently there's, some people in Canberra talking about workforce issues at the moment. But I think where the real difference we see in mental health and other kind of human services is that if we don't solve these workforce challenges, they really are impacting on the community and impacting on outcomes. Colman, I might start with you here, but really keen for kind of input from everyone on this one. Are there some things we can do to solve some of these workforce challenges, particularly with the fact, we can't train a psychologist or a psychiatrist overnight. It's a long time period. So what can we do in the shorter term to kind of solve some of these issues and improve service delivery?
I do think workforce is a really big challenge for us, and some of the things that Sam just spoke about contribute to the challenges we've got with workforce. When people enter a profession for a certain reason and then they find themselves working in an environment where they're really only dealing with from one crisis to the next crisis to the next crisis, it contributes to the loss we see and the exit from these professions. So that sense of overwhelm and burden means we lose people and we don't get people. It also means that they're not attractive professions for people to enter in the first place. Like you say, it takes years to grow a workforce, and we don't have a strategy for doing that. I think some of the things that we heard the Victorian government announce in relation to, say, nursing workforce and making education for our nurses free in Victoria, those are some sensible steps that we can do. These, by and large, these are not professions that are going to make you a very wealthy person. So whatever we can do to reduce the burden of entry into the professions in the first place, but also make them attractive and rewarding career prospects for people, the better. And I think that needs a defined, coordinated approach across the sector in order to do that. But that's not a short-term fix. And I am struggling to understand how we fix this in the short term. Having our borders closed for 2 years hasn't helped us as a country that is largely reliant on migration and skilled migration. I think across the healthcare system right now, where we are seeing the impacts of that, because like me and others, a lot of our healthcare workforce comes from somewhere else. So I think in the short term, we need to really put an emphasis on how do we bring those skilled migrants back into the country. And I'm sure that's being discussed in Canberra right now. But then we also need to look at our care models and understand, well, who are the people we need? What are the skills those people need at different parts of the consumer journey through that care model, so that we can build out the right workforce? So I think all of these things intersect with one another. But for me, often it starts with understanding what are we trying to achieve and who are the right people to deliver the kind of evidence-based care that we know needs to be delivered at the right time. Again, just changing the access points to an existing workforce isn't going to increase the size of the workforce. And I think to Sam's earlier point, we also need people to be working at the top of their game. So we need our most skilled professionals dealing and working at the top of their expertise, not necessarily further down the tree. And I think that's a real challenge for us as well, with the way in which our system is organized, because sometimes we have very skilled people working in a part of the mental health system that perhaps somebody with a lower degree of skill or somebody who is in training could be working, whereas they should be working in another part of the system. I think we have lots of challenges with how we orchestrate the system, because to Tim's point, that the idea of strategic procurement or strategic commissioning is a really challenging one, and it's like we have a system that is a system in name but not in practice. So we have a bunch of people all playing instruments, but there's no conductor. We don't really have a system orchestrator, and until we get to that point, I think it's going to continue to be a challenge, because we can't prioritize which workforce gaps we fill first, because we have nobody thinking about this systemically.
Great, thanks, Colman. Some good insights there. Tim, have you got something to add?
Yeah, I would add to that and totally agree, Colman. We don't have enough system thinkers that are dedicated to designing the service systems. So what we end up with is just a labyrinth of services, which is why people find it hard to navigate services. I think the workforce issues are not just psychologists, psychiatrists, people that take a long time to train. It's also those that are working in the community support space as well, supporting individuals on their recovery journey. And part of the issue is one of attractiveness of those roles. More often than not, they're award wage roles. They're often precarious in terms of the nature of employment by virtue of short-term contracts, and there's funding issues there as well, because we know a major problem for the sustainability of services is certainty of funding into the future. And often services are running on 12-month rollover contracts, and it's really hard to sustain a stable workforce when people can't see whether or not the service is going to be continuing in 12 weeks' time. So that's a really significant issue. It comes back to the strategic commissioning question as well. Improving pay and improving the security of work for community support workers also will go some way to addressing the gender pay gap. With many of those roles or many of those services dominated by female employees. So I think there's a gender pay equity opportunity there as well. There's also opportunity in terms of peer workers. And again, from evaluation work that we've done at Nous, we've been able to establish evidence that demonstrates while peer workers in a service may not necessarily change, if you like, the clinically measured outcomes, mental health outcomes for individuals, what it does change, and the evidence is very clear, is it improves their experience of that service. And if their experience of a service is positive, then their willingness to participate and engage with those services is much higher. So there's a significant opportunity to improve the service experience through involving peer workers. And we know that a lot of people with mental illness don't have positive experiences of services. So we need to find ways to address that. Peer workers are a fantastic opportunity. Having said that, we shouldn't assume that they're there to just be a cheap source of workforce either. Peer workers come with experience and expertise and perspective that other workers don't. They have gained that experience and expertise and perspective through their lived experience, which is hard. And they should be recognised appropriately for that in the way that they're remunerated.
Thanks, Tim. Sam, I might throw to you now. It's been a bit of an interesting past few years with COVID, and there's been a lot of talk about the impact that's had on mental health, and particularly mental health of kind of different generations. So there seems to be particular concerns about young people. I'm just wondering on your thoughts on that. Are there increasing levels of mental health issues in younger generations? How do we balance that in terms of service provision, and also making sure that we're, looking after all generations and everyone in our community?
Yeah, so we Black Dog Institute produced a white paper looking at this question last October in Mental Health Month. And prior to 10 years ago, the overwhelming evidence for across developing countries was that rates of mental health symptoms weren't really changing much. Certainly there were increasing numbers of people going on sickness absence, long-term sickness absence related to mental health, but that seemed to really be about sort of less stigma about attributing that label to what was going on. It was a sort of more accurate reflection of what had always been there. What's happened over the last decade, though, in Australia and a number of other countries, is a pretty striking pattern of, amongst adolescents and young adults, an increase reporting of mental health symptoms. And we've seen this now in multiple different surveys. And the honest answer is we don't know quite what the reason for that is. Just to be clear, this is not saying that we're diagnosing more depression because GPs know how to look out for it or things like that. This is when you go out in to find a random sample of the population, you ask some questions about, are you having this symptom? Are you having that symptom? Those mental health symptoms, particularly those of depression or anxiety in adolescents and young adults, have increased year on year over the last 10 years. They jumped particularly during COVID, and particularly where there were areas of lockdown. They appear to be sort of settling back down now, but we haven't quite had the new data in to look at that. The question as to why, we're seeing very different patterns of symptoms across the lifespan in different generations. So people in my generation, and for a number of generations before it, there was a very clear pattern that individuals had high levels of symptoms in their adolescence and early adult life. And then generally, as you moved into your 30s and 40s and 50s, your level of symptoms gradually decreased. Some of that was probably biological. Some of it was just in terms of the stage of life you're at. And then there was a sort of another peak of symptoms in older adults. And there was a similar sort of matched two peaks in terms of for suicide outcomes. What we're seeing with successive generations now, if you look at people who were born in the 1980s, people who were born in the 1990s, they're following a very different pattern. Not only are they emerging from adolescence with more mental health symptoms, the symptoms are not reducing as they move through into their sort of mid-adult lives. They're staying the same or maybe even drifting a bit in the wrong direction. Now, is this because we have a less fair society, they have less job security? Is it because they can't buy a house and be secure in the way that previous generations were? Is it because of the internet and social media? The honest answer is we don't know. I think it's reasonable to wonder aloud whether it's partly because of the way in which we have talked about mental health to those generations from the time that they were in late primary school onwards, and have we chipped away at their resilience by doing that? I think, for me, it's extraordinary that we as a society don't have an answer to that question. Just about every other health condition you can think of, aside from obesity, the legacy that we have is to hand on better outcomes to the next generation. Mental health, that's not happening. We're handling on significantly worse mental health to the next generation, and we have no idea why.
Thanks, Sam. That's incredibly interesting, and I think clearly a case for some further research there, something we need to keep on top of. Tim, I might come back to you now. You've mentioned some of the evaluation work that you've done through your current role at Nous Group. I'm wondering if there's some other kind of lessons that you can share with our audience today, what you've kind of learnt from that process, and what are kind of some of the more kind of practical implementation things that we could be doing in this space?
Excellent question. Thank you, Cassandra. I think one of the first things is we know that people find it very difficult to navigate mental health services, and that the mental health service system is full of gaps and overlaps. And people fall into those gaps, and often they don't re-engage with services for some period of time if they have a bad experience. Service integration is absolutely critical, but we rely on it happening organically. And as a result, we get an organic outcome, and it's often based on relationships, pre-existing relationships across individuals, across different services. And we need a much more systematic and rigorous approach to service integration. And I would love to see, every time a new service is developed and implemented, that part of the component of that service is resourced to integrate with other services. Because unless we resource it, as I said, it's organic and it's hit and miss. So that's a key learning from some of our evaluation work at Nous. Also, planning the location of services is critical, because often it's a bit hit and miss in terms of state funded services locating, and also Commonwealth and primary services and where they locate. And again, it's not deliberate in terms of creating an ecosystem of services. So again, it's disjointed, hit and miss. And with service design and system design, we really need to realise the opportunity through data collection and quality data to analyse and inform the planning of future services and service design. We are underutilising the data we have. The data we have is not always of great quality, but given the scarce resources we have to invest in services and the mental health system, we need the evidence to tell us where services need to be and what those services need to be. And the data can tell us that, but we need to put a lot more effort into quality data and analysing that data to inform decision making.
Thanks, Tim, and love any discussion about data, and certainly one of my passions is really using the data that we do have more effectively to try and really get the best outcomes that we can from the money that we are spending in this space. So yeah, always keen to push for more of that. Colman, I might come back to you and touch a little bit more on the funding issue here as well. And we have had a question come through on Pigeonhole about the role of Medicare here and whether we need kind of more universal healthcare, mental health services provided through Medicare. I'm interested in your thoughts on that. And also, and maybe kind of a bit of a broader question is the issue that we don't have enough funding, or is it more how the funding itself is distributed? Any thoughts, Colman?
Yeah, I do have some thoughts on that. And if there's any other Irish people listening, this will make sense to you, because I suppose if you ever ask for directions in Ireland when you're driving, someone will say to you, well, if I wanted to get there, I wouldn't start here. And so if we wanted to design a system for delivering mental health care to our population, I don't think we'd start with the way in which Medicare is constructed. Having said that, we've got it, and we're not going to have whole-scale revolution of the Medicare system, but we do need to address that particular issue, because we have essentially a demand-driven system to draw down on funding that is in no way connected to outcomes or the quality of the care that is provided. And so we have a huge amount of money being spent in a system without understanding really if it's meeting the needs or it's meeting the priority needs. So Sam made the point earlier that he, as a psychiatrist, can see somebody for an hour and gets paid a certain amount, and there's no real link to outcome or need in that transaction, and it is transactional. And so I do think before we really answer the question about do we have the right quantum of funding, we need to look at how that funding is distributed and the way in which it's prioritized. And I think there's been a lot of discussion of that today, the need to have a system orchestrated at a regional level, at a state level, and a national level, because communities are different. And we need to, I think about this challenge as a community challenge as well as a challenge for individuals, because many of the things that we should be doing and could be doing in early childhood education and in schools will help to offset the development of some mental health problems later in life. And so we need to see those as investments in mental health care. So for me, it's about building out a system that responds to the need in a way that's driven by data and driven by evidence, that then overlays a model for funding that drives the right sort of outcomes and doesn't just drive transactions or widgets of activity, because that's generally how we seem to measure success. I heard somebody else describe this as a pilot flying a plane and determining whether they got to the destination based on how much fuel they had consumed. That seems to be how we do things in the mental health system. We talk about how much money we spend rather than whether or not we achieve anything. And Sam's point about the mental health of younger people, it's pretty damning, isn't it? That with all our advances in healthcare, we're handing on to the next generation a poorer state of play than the one we inherited, it would seem.
And
yeah, go ahead.
Cassandra, can I just add on to that? I totally agree with everything that Colman said there. The only thing I would add is there are even some minor tweaks that we could be doing around the funding system at the moment that we're not doing. At the moment, the way in which most mental health clinical services are funded relies on, it encourages clinicians to keep seeing the same patients rather than to see new patients. So we end up with this situation where clinicians' books are full and there's no spots for new appointments. Indeed, even the government's response to, one of their responses to what was happening during COVID was to double the number of Medicare-funded psychology sessions. Well, that increased the wait time to see a psychologist if you weren't already in the front door. GPs in Australia, you earn less per minute doing a mental health consultation than you do a general consultation. The system discourages GPs from dealing with mental health problems, even though we know mental health's the number one thing walking through their door. So there's all sorts of sort of crazy, perverse incentives going on in the system at the moment, and why ultimately I think we do need to get to one that sort of looks towards what we want to be happening in those clinical encounters and looks towards outcomes. Even before getting to that point, there's some sensible things we could be doing.
Thanks, Sam. Tim, you have some thoughts here?
Yeah, and it's kind of a little bit more fundamental and goes back to Sam's earlier comments around adverse childhood events. We're spending too much money far too late in people's journeys to mental ill health. We know that young people that have adverse childhood events are far more likely to develop severe and persistent mental illness or moderate mental illness in the form of mood disorders and alcohol and other drug issues. Yet for a large proportion of those young people, we're aware, either through education systems or through child protection systems, we're aware of the incidence of trauma. The evidence tells us what the impact of trauma is, yet we wait until that impact is realised in typically teenage years. If our funding was geared more to that earlier intervention, more proximate to the point of those adverse childhood events, then the trajectory for those young people, which ultimately impacts their entire life course, could be very, very different. And the return on that investment, far greater than investing more in acute settings. Sam and Colman probably might not like that from an acute clinician perspective, but the reality is...
Tim, I think you're absolutely right. I mean, the way you describe it as we're spending far too much money far too late, I think is a beautiful way of describing it, because we're spending money doing as Sam has described, giving people incentives to keep seeing the same people. But if we could shift some of that investment to much earlier in life and do the things that Sam has talked about earlier that we know are effective in early childhood to deal with those social determinants, that would be a much smarter investment in many ways. It's harder to do, but that's why I feel like we need to be more unreasonable about what we're trying to achieve here, to break the mold a little bit and do the things that are harder to do because they pay off.
I think the reality is we're never going to be able to shift money away from that acute end into the earlier intervention space. What we need to be doing is investing a lot more rapidly in that earlier intervention space than the acute end. So definitely not taking away from the acute end, but adding far greater to that earlier intervention.
Yeah, when we've got new investment, we should be going earlier for sure, because taking away is not going to work. That's just going to make things worse. But I think Sam's right. There are ways to tweak how that money flows to make sure that it's greater access for new people needing to access care, rather than people already plugged into the system getting more access.
So I think we're all three of us arriving at the same position from three different perspectives, and it's time to take the campaign on the road.
Sounds like we've got a plan here. Look, we're running close to time. Just wanted to kind of give you each an opportunity to make a quick final comment, and maybe, what would be your kind of number one reform if you were, we've got a relatively new government and they're hopefully interested in ideas. Just pretty briefly, what would be the number one thing that you would take to them? Tim, I'll start with you.
The number one thing would be three things. A focus on system design through strategic commissioning, a greater investment in earlier intervention, as we just discussed, and community support programs, and greater focus on evaluation and evidence to inform decision making.
Thanks, Tim. Colman?
If I got to ask, I'd ask for some of the things Tim's asked for, as well as a commitment to reshaping the way in which funding systems flow in the existing model, so that it can start to incentivize the kinds of activities that we want to see. I really think that's a pressing need.
Thanks, Colman. And Sam, final word to you.
Well, I'm not going to stick to one idea now nobody else has. I'll go with three as well. Number one, we need a proper plan to increase the mental health workforce, short and long-term initiatives. Number two, we need a review of the mental health Medicare item numbers, both primary care, specialist and allied health. And number three, we need a independent mental health policy unit that can actually help the government and policymakers by evaluating these new ideas, by evaluating models of care and giving evidence-based advice around what should be being invested in.
Fantastic. Well, look, some great ideas there from everyone and some fantastic discussion today. So certainly more to be done in terms of continuing to promote the need for reform, and as it sounds like, not maintaining momentum, but actually increasing momentum. So I think on all of us that are either speaking or listening in today to do our bit to make sure that we work towards that. Thank you so much to Sam, Colman and Tim for your time today. You've really shared some incredible expertise with us, so thank you so much. And thank you to the audience for your active participation. Great to see so many questions come through on Pigeonhole. I'm sorry I didn't get to all of them, but really appreciate the efforts you've put in there. Please do take a moment before you log off Pigeonhole to rate the live stream today. That's really useful feedback for our team. This discussion has been recorded, so you will get a link to it in the post-event email, and it will also, in a week or so, be available on our website if you want to share it with any colleagues. Please stay in touch so you can look up what else is coming up at CEDA at ceda.com.au. So we've got a pretty full schedule of live streams and face-to-face events coming up. And particularly next week, we have State of the Nation, our flagship national event in Canberra. So I hope to see some of you there. And a huge thanks to St John of God Healthcare, our sponsors for today's event. So for making today's event possible, we really appreciate your support. So thank you, everyone. Enjoy your afternoon and have a lovely weekend.